Good afternoon. We're going to get started. It's noon. We want to welcome everyone for joining us today. My name is Gina Flores, and I'm the CMQCC Communications Manager. Today, we are here for the webinar, Tackling the Midwife Question. What is midwifery integration, and why is it important for moms and birthing people in California? This webinar and live panel discussion is intended for California hospitals and other stakeholders in maternity care quality improvement. Next slide. Everyone is on mute today, and only our co-hosts and panelists will be on camera. The slides and the recorded webinar will be posted on our webinars page on the CMQCC website early next week, Monday or Tuesday. So if you have colleagues who weren't able to make it today or want to watch it again, it will be on our webinars webpage. The Q&A function during the webinar is going to be open, and our clinical lead, Krista Sakowski, a CMQCC clinical leader, registered nurse, and expert in quality improvement, will respond to those questions. Once a question is answered, it will appear in the Q&A. Please allow only CMQCC to respond to those questions. Thank you. And next slide. So you are able to use this webinar. Once we post those slides, you can use them for educational purposes. If you do change anything, please remove the CMQCC logo. We welcome your feedback, and of course, we will also be having an evaluation, so you can provide your feedback about the webinar, etc. And let us know if you need anything different with the slide set at our info@cmqcc.org email address. Next slide. This is an educational event, and these slides should be used for education. Please always refer to your local facilities, level of care, and patient populations that you serve. And please do not rely solely on the guidelines that you'll hear today. Next slide. If you are looking for continuing education credits, please look closely at these instructions and complete the evaluation, which will arrive in your inbox tomorrow. And again, on that, you must stay on the call. Well, just stay on the whole time, but at least 50 minutes. Thank you. And then finally, we want to put up this inclusive notice. All persons are equally deserving of respectful patient care. So the CMQCC team and all health teams should respect individual patient preferences regarding gendered language throughout the course of their care. So I am going to introduce Holly Smith. She is a CMQCC expert consultant, a certified nurse midwife, a master in public health, as well as an expert in the topics we're discussing today and throughout this webinar series. Holly is also the lead editor for the Toolkit to support vaginal birth and reduce primary cesareans, which Holly will talk more about as she facilitates today's discussion. So Holly, I'll turn it over to you.
Thank you so much, Gina. I just want to give a big welcome to today's panelists. First, we have Eva Goodfriend Riaño, who is a nurse midwife and the midwifery clinical chief at Highland Hospital, which is part of the Alameda Health System. She helped to lead their hospital's Reducing Primary Cesarean initiative in 2018 and 19, and also was integral in bringing intermittent auscultation to her institution through the development of the policies and the training for staff. She has worked with Alameda Health System since 2014, and prior to that, spent 6 years as a home birth midwife. So she brings a very deep experience and perspective regarding supporting vaginal birth and also the challenges that community birth providers and families face when accessing care. She was also a midwife at Sutter Davis Hospital in Northern California prior to that. She is part of the Birth Bridges Perinatal Collaborative as well, and was also a key part of the task force that created the midwifery integration recommendations for the update to CMQCC's toolkit to support vaginal birth. Sue Balin, licensed midwife and CPM, is a graduate of the National Midwifery Institute and owner and principal midwife at Sacred Body Midwifery, a home birth practice serving San Francisco and the Bay Area. And she's been in that role since 2005. She is a member of the San Francisco Home Birth Collective and the Bay Area Home Birth Collective, as well as the Birth Bridges Perinatal Collaborative. She is involved in other statewide endeavors as well, like the Institute for Medicaid Innovation's California-based initiative to improve midwife-led care in Medicaid, and brings the perspective of a licensed midwife in California, meaning a non-nurse midwife, which is really critical to our discussion today. And finally, Dr. Mimi Niles is an assistant professor and nurse midwife at NYU Rory Myers College of Nursing. Her work explores the potential of integrated models of midwifery care in creating health equity in historically disenfranchised communities. And she is trained in utilizing critical feminist theory and qualitative research methods as a means to implement policy and programming rooted in intersectionality and anti-racist frameworks. She is a practicing midwife serving within the largest public health network in the nation. She provides full scope midwifery care in a collaborative practice setting in Brooklyn, where the midwives attend 90% of all births. Currently, she is the only appointed midwife to sit on the New York City Maternal Mortality and Morbidity Review Committee, and she received her postdoctoral training under the mentorship of Dr. Saraswati Vidam at the Birthplace Lab at the University of British Columbia. And we'll talk about the Birthplace Lab and just their amazing tools and resources that they have available that are also included in our toolkit. So thank you to our panelists for being here today. See if I can get my slides to move. Our objectives today are pretty simple. We are going to define the meaning of midwifery integration at both the macro, meaning the state and federal levels, and the micro level, meaning the clinical and interprofessional levels. We're going to describe the importance of midwifery integration as a necessary component, if not critical component, of quality improvement in maternity care. And we're going to hopefully help you identify opportunities and challenges for midwifery integration where you're at. So just a reminder, this is number 3 in a 5-part series. This series of webinars is meant to introduce the new content in part 5 of the Toolkit to Support Vaginal Birth and Reduce Primary Cesareans. You can find the other 2 previous webinars on our website at cmqcc.org. Today we'll be talking midwifery integration, but in August, we'll be discussing partnering with doulas. And then by October, we will be focusing more on community birth and improving transfer of care. The community birth component is also going to come up in discussion today because it's part and parcel of midwifery integration as a whole. So many of you have seen some of these slides already. They were in our last webinar in February, but it's important, I think, for us to start from the beginning and explain why we are talking about midwifery integration as one of the key tools for quality improvement and reducing disparities by race and ethnicity. So first of all, many of you on the call have been involved in our cesarean reduction efforts across California, and we really thank you for that. Your work has led to some very impressive results in both reducing cesarean rates as well as reducing maternal mortality and morbidity in California. But as you can see from this slide, something really stands out. And that is that the disparities by race and ethnicity for cesarean birth still exist, and the gap has not closed. Black birthing people and people of color have higher rates of cesarean, and that goes for maternal morbidities in general and mortality. A recent report by the California Department of Public Health and CMQCC using an enhanced surveillance method showed that Black birthing people, in fact, have a risk of maternal mortality that is 4 to 5 times the risk of white birthing people. So we're here for reasons of establishing birth equity. And here at CMQCC, we utilize the definition by Joya Creer-Perry, the founder of the National Birth Equity Collaborative. And that is that birth equity is the assurance of the conditions of optimal births for all people with a willingness to address both the racial and the social inequalities in a sustained effort. So that means that achieving birth equity means we have to utilize strategies that consider the root causes of disparities. And midwifery care is, in fact, because of its holistic focus on a patient's upstream determinants of health, is one of those strategies that considers the root causes of disparities. Achieving birth equity also means we need to consider community needs and wants in our approaches to quality improvement. And we have seen from reports, for example, from the California Healthcare Foundation, the Listening to Mothers in California survey, that people are looking for and either want or would consider midwifery care as their future maternity care. So the community is asking for this. Achieving birth equity also means having the humility to accept that what we're doing right now maybe isn't working for everyone. And I know that that can be a hard thing to accept, since none of us come into this work with the hope that we only will do partially well, or that some people will benefit and others won't. Obviously, nobody is here for that. But nonetheless, we have to personally take responsibility to accept that the kind of care in the main is not working for every person and isn't reducing disparities in the way that we had hoped. And so it means bringing all the quality improvement pressure points to bear and using all of the tools in the toolbox. And in this point, midwifery integration is one of those tools that has not yet been tried to any significant degree, which is another reason why it's the next step in our quality improvement process. Here we see a slide of the quality improvement ecosystem. We bring this up because our work at CMQCC is focused truly on those clinical improvements that you all can personally make or make collectively in your system. There are certain things that obviously you don't have personal control over, like payment reform or health workforce expansion, or perhaps structural racism. You may have some input into implicit bias for yourself, but there is only so far you can go as a person. And we want to acknowledge that, because I sometimes feel like this can feel very heavy, like we're asking folks to change the world in a moment's notice. We're not actually doing that. We are asking that you consider the clinical improvements that we are going to put forward today as some of the low-hanging fruit that you can work on. All the while, however, keeping in mind that there are social policies that certainly need to be changed to address the upstream determinants of health, because what the patient brings into the prenatal care visit or into the birthing room are all the things that they live in and work in and were born into every day. So their education, their exposure to substance use, whether that's food insecurity or housing insecurity. These are the things that midwifery care also has embedded in our processes and the kind of care that we give. So again, something that we should all keep in mind, but we're hoping that the clinical improvements we show today is something that you can begin to implement. Now, when we talk about midwifery care, it does bring up some maybe some feelings for folks. And we just want to do some level setting around midwives and community birth. And we invite you to participate today, hopefully with an open mind and curiosity. Because truly all of this is about providing patient-centered care, or the kind of care that is respectful and responsive to patients' needs and their preferences and their values, and ensuring that those values guide all clinical decisions. So to that end, we want to acknowledge that there is no singular intervention that will reduce cesarean rates or eliminate birth disparities. And that includes midwifery integration. It is not a magic pill and won't solve everything. But nonetheless, it's important for us all to recognize that CNMs, CPMs, and CMs, these are all the different midwifery credentials types, all of us meet or exceed the International Confederation of Midwives training standards. All licensure types provide unique expertise and are needed to improve maternity outcomes and fill gaps in care. And finally, community birth is safe. The evidence shows that. So today we're not going to be arguing about whether it is safe or not. We know that it is, but it's safe when it's provided by trained, skilled providers, when risk assessment is ongoing, and when it occurs within an integrated system of care or higher levels of care and medical consultation are easily accessible. And we aren't the only ones that know that or think that. Just in January of this year, the Joint Commission released this Sentinel event alert on eliminating racial and ethnic disparities causing mortality and morbidity in pregnant and postpartum patients. And they noted that in order to do that, we need to provide support and options that meet the needs and expectations of patients, including those that wish to deliver in a home or birthing center environment while managing their risk of pregnancy complications. There is also now a multitude of newer publications and studies that are calling on clinicians and providers and others who can affect policy change as well to really see and view midwifery integration in a new light and in a way that shows their support for midwifery as a critical part of considering those root causes of disparities. So I encourage you all to take a look at some of, they're included in the toolkit as well, to take a look at some of these resources. But it seems to me like we're finally on a tipping point where we're seeing midwifery integration as one of the next big steps for quality improvement. I want to thank Dr. Niles for sending this over today. This was literally just dropped from the Commonwealth Fund this last Friday. On how expanding the role of midwives in US healthcare can help address the maternal health crisis. Specifically circled here that the integration of midwifery as a standard feature of maternity care services varies dramatically across states, but we know that the outcomes for mothers and infants tends to be better in states with high levels of integration. I also just want to point out here that this photo is of Kimberly Durden, who's a wonderful midwife down at Kindred Space LA in Los Angeles. All right, so let's jump into what midwifery care is. So the midwifery model of care is actually the standard of care in all countries that have better birth outcomes. Patient empowerment is a central theme of the care that we give, and it's what we would call whole person care that considers all of the patient needs, everything that they're bringing into the visit with them, whether that be their physical or emotional situation, social determinants of health, personal values, and cultural needs. The World Health Organization describes midwifery care as skilled, knowledgeable, and compassionate care for childbearing women, newborns, and infants and families across the continuum from pre-pregnancy, pregnancy, birth, and postpartum, and even the early weeks of life. And here in the US, depending on the midwife scope of practice, we also do family planning, well-person GYN care, gender-affirming care. In California, nurse midwives also do abortion care, medication abortion, and aspiration abortion in the first trimester. So here's what I was speaking about earlier in terms of midwifery care around the world. And you can see in those countries that have better maternal mortality and morbidity rates, Germany, Norway, Australia, Sweden, all have a greater proportion of midwifery births. Looking at California then, you can see over on the right side of your screen, this just kind of gives a quick view of the number of births back in 2017. This data is from the California Healthcare Foundation. Clearly, the greatest majority of births are done by physicians. Nurse midwives do about 50,000 births per year, licensed midwives, a little over 3,000 actually, and putting us around 11 to 12% of the births in California. So here's a quick graphic just to kind of outline the kinds of midwives we have in California. You can find this information in the toolkit as well, and I encourage you to go there and read through it and become accustomed with the vernacular and where certain midwives work. So you can see here that CNMs attend births mostly in the hospital setting. Both licensed midwives and nurse midwives attend births in freestanding birth centers, and then both licensed midwives and nurse midwives attend births in the home setting as well. In terms of education and training, typically nurse midwives finish a nurse midwifery education program approved by the Board of Registered Nursing, and then they are able to sit for the American Midwifery Certification Board exam, also known as the AMCB exam. And this is what confers the CNM certification. LMs in California, so again, this is different state by state, so I just want to make that clear, but LMs in California finish a 3-year midwifery education program approved by the Medical Board of California, and then they are able to sit for the North American Registry of Midwives Board exam, or what's called the NARM exam, which is what confers the CPM certification. And then this is just another way of looking at births by setting and by midwife in more of a numbers view in California instead of the graphic view. So you can see there at the top right-hand side, nurse midwives do most of their births in the hospital setting, 97%. Around 1.5% of nurse midwives do births in the freestanding birth center, and a little less than 1% in the home. It kind of flips then when you look at licensed midwives. The vast majority of licensed midwives are doing births in the home setting, and then a lesser amount in birth centers. And again, I just encourage you to dig into the toolkit, specifically if you're wondering about or need resources for midwifery educational requirements, the various credential types or scope of practice, to take a look at table 40 in part 5 of the toolkit. So the benefits of midwifery care. Many of you have seen this slide before, but with midwifery care, clients are more likely to have a spontaneous vaginal birth, more likely to have a trial of labor after cesarean and a successful VBAC, higher rates of breastfeeding, higher rates of patient confidence and control, lower cost, and are less likely to have a cesarean birth, an operative vaginal birth, induction of labor, episiotomy, and other interventions, like the use of pain medication or continuous fetal monitoring, or even NICU admission. Studies are showing that this is the case for low-risk patients, but also this the same applies to moderate-risk clients as well. For example, patients with certain health-related social needs or social determinants like substance use or mental health conditions, we're actually finding that those folks may really greatly benefit from midwifery care and the one-on-one high-touch care that midwives give. And also because our philosophy of care is one in which we are connectors to community programs and other psychosocial interventions. So when we designed the recommendations in the toolkit for midwifery integration, I actually want to thank Eva, who is one of the panelists here today. She thought, and others in our group thought, it was really important to describe what midwifery care is, though. What are the components? So if you get into the toolkit, you will find there the pearls of midwifery, and you will also see how it is in direct alignment with ACOG's recommendations for low intervention care as well, and how those are perfectly aligned. But if we were to talk about midwifery in a nutshell, there are 3 basic elements. That is patient-centeredness, the therapeutic use of the human presence, which I think is just a beautiful phrase to describe how midwifery care uses a relational model. And that source is from an article by Margie Hutchinson at San Francisco General. It's also in the toolkit if you'd like to read that. And then finally, non-intervention unless it's necessary for the health and well-being of the pregnant person or fetus. So that, I think, really encapsulates the model of midwifery care with 3 basic definitions. So now we're going to talk a little bit about the history of maternity care in the US and midwifery in the US. First, I will say that these slides are not meant to be an all-inclusive look at the history of maternity care in the US, that we would need an entire webinar on that, if not an entire semester. So instead, we just want to point out some major issues that got us from 1900 to here, where we're at now. These slides, I want to thank Paris Malouf-Burry, who's this California Nurse Midwives Association president, who did a great webinar on marginalization of Black midwives in America at our annual meeting last year. So thanks to her for letting us use her slides here. But what you can see is that the US has a rich and pervasive history of midwifery since this country was established. Immigrant midwives, indigenous midwives, grand midwives, or what were also known as granny midwives, mostly in the South, created a really rich tapestry of midwifery history and contributed to the healthy births of people who would otherwise not be able to obtain care due to segregation, for example, or who were simply socially or geographically isolated. But unfortunately, the history of midwifery and the attempted eradication of midwifery, particularly the eradication of midwifery by Black midwives, is also part of our history. And that is rooted in racism, classism, sexism, because midwifery is a mostly female vocation and still is, and simply a result of a power struggle that ultimately subordinated midwifery in providing care to pregnant people and their newborns. So in 1900, less than 5% of births occurred in the hospital setting. In 1910, the Flexner report was published, and I'm sure many of you are familiar with that report, which advocated for the abolition of midwifery and also for underperforming medical schools, which included the abolition of medical schools that were training Black physicians. This study has since been recognized for its racist and sexist and classist approach to medical education. Nonetheless, in 1915, Dr. Joseph DeLee described childbirth as a pathologic process and stated that few escape damage, quote unquote. In fact, he went on to say that it is generally admitted that more women die during confinement in the hands of doctors than midwives. And because of that, the energy directed towards training midwives would bring greater results if spent on doctors. And that's how that shift from midwifery care being primary maternity care to physician care being primary maternity care. Additionally, and I should also say that Dr. DeLee proposed a sequence of medical interventions that were designed, albeit designed to save women, but were highly interventionist. He believed that obstetricians should sedate women at the onset of labor, allow for the cervix to dilate, give ether during the second stage of labor, then cut an episiotomy, deliver the baby with forceps, extract the placenta, give medication for the uterus, repair the episiotomy, mom wakes up and all is done and all is good. And as we know, many of these interventions became routine. And in fact, many of these interventions in the sense of controlling people's bodies also became routine. I can remember my own grandmother saying that in 1964, when my uncle was born, it was her fourth child, that her physician said that she didn't have to have her hands tied to the table anymore because it was her fourth baby and she could do it. I remember my mom saying that when she gave birth to me, I was her third C-section, and due to the significant hemorrhage she had, that her tubes were tied without her consent. I can remember training as a midwife in 1999 and seeing students do exams on anesthetized people without their consent. That doesn't seem that long ago to me. Of course, nowadays we would not think of doing that. But there was, from the beginning of the 1900s till now, a pervasive culture of simply controlling people's bodies and controlling patient care. In 1925, Mary Breckinridge founded the Frontier Nursing Service in Kentucky. And after that, pretty much the first nurse midwifery schools were established specifically to attend to special populations who were isolated by geography, poverty, language, culture, or other issues, which, by the way, is still the philosophy of nurse midwifery. But unfortunately, what happened here is nurse midwives, or I should say, public health nurses made the choice to align midwifery with nursing, which may have been a critical misstep because it delegitimized other kinds of midwives, and that has that has survived until present day. I will say that I am a proud fellow of the American College of Nurse Midwives. I'm proud to be a nurse midwife, but I want to acknowledge how nurse midwifery, along with the traditional medical system, have harmed the rest of midwives in America and essentially abolished it. Okay, so moving on, you all can read through this since we're kind of getting low on time, read through this at a later time. But I just want to note the following, that CNMs were authorized to practice in California in 1974, but it wasn't until 40 some odd years later that we gained independent practice in California. That was back in 2020. Licensed midwives were authorized to practice in California in 1993. It wasn't until 20 years later, though, that independent practice was established for them. And I feel happy to say, however, that it feels like we're at a special time in midwifery history that we haven't seen for a very, very long time, a tipping point, if you will, where, as I said previously, that advocates, clinicians, midwives, physicians alike are noting midwifery care to be a key strategy towards reducing maternal mortality and morbidity, and community birth and hospital midwifery are both on the rise now. All right, I did not do justice to the history of midwifery in the US, so I am going to play this video. It takes about 4 minutes, and then we'll move on to the next parts of our talk.
Holly, I'm not hearing any audio. When you originally shared your presentation, did you click the box that said share audio?
All right, I'm hearing from folks that there is no sound. Just know that it's just music in the background and everything is written on the screen. Sorry about that. All right, sorry about that, that you weren't able to hear the actual music in the background, but I hope this gave a little bit more background on the history of granny midwives in America. And this will be included also in the slides that you can download. And so I just encourage folks to watch it if you weren't able to hear it or see it very well. Gina, are you able to hear me now?
Yes, we can hear you great. Thank you.
Okay, very good. It feels like I'm talking into a tunnel. I have no idea. All right, so let's step into midwifery integration as a whole and what that is and do our best to describe it. So what does a system of integrated midwifery care actually look like? In fact, there is no universal definition, so that does make it a little bit difficult, but I kind of think of it like how we define high risk, and that sometimes it can be a little difficult to define, but we know it when we see it. In the same way, we know midwifery integration when we see it or when we see it done well. We could also draw from other definitions of integrated healthcare generally and accepted definitions of integrated maternity care. According to ACOG and the levels of maternal care, that document really gives a good indication that integrated care relies on enhanced coordination, cooperation, communication, and assessing risk on an individualized basis. And other countries can serve as a model for us as well. Now, you might be wondering, though, does midwifery integration really matter? Why does it matter? Couldn't we just continue, for example, in a parallel system of care that allows folks to be seen by whoever they want, but why is the integration component really important? Well, we know from other parts of medicine, other industries as well, that that collaboration and seamless coordination of care means that there will be fewer catastrophic intrapartum outcomes and also fewer catastrophic outcomes during critical events. It may even prevent critical events from happening. And we also know on the flip side that that interprofessional disconnect or poor communication centers the provider, uncenters the patient, and creates an unsafe care environment. So midwifery integration also matters because it turns the current culture of doing too much too soon into giving the right care at the right time. It reduces healthcare costs, hopefully, and we have evidence that backs that up. It increases access for those who need it most. It improves choices in childbirth. It results in respectful and patient-centered approach to community needs and wants, and it's a huge and strong step towards reducing disparities in outcomes. So back in 2018, there was an amazing study that was very nuanced and new in how it looked at midwifery integration, and it really provided for us a map at the macro level of what midwifery integration looks like across the US. This was done by Dr. Saraswati Vidam and other experts at the Birthplace Lab. Go to birthplacelab.org if you want more of their resources, which are wonderful and amazing tools. So the aim of this study was to create a transdisciplinary national research project to examine the impact of the state regulatory environment on access to midwives and association with perinatal outcomes across populations in the United States. So they looked at all 50 states and scored the level of integration for each state. And those integration scores were based on things like prescription ability to work without supervision, the ease of communication and transfer to higher levels of care, and then compared these scores, these integration scores to each other alongside the overall outcomes, birth outcomes in those states. So I'm not going to actually do it justice by describing it because it's actually a very statistically rigorous analysis. But what it showed was that in general, where there are arbitrary regulations that center maternity care in more of a pathological or medicalized culture of birth, and they only serve, those arbitrary barriers only serve to create barriers to access to care for folks and potentially could be harmful to their birth outcomes. What they found was that increased access to midwifery care is correlated with improved outcomes such as increased breastfeeding, reduced interventions, higher rates of VBAC, lower neonatal deaths. All right, I'm going to give this a try. I'm going to take off my earbuds and see if you guys can hear this.
When midwives are a part of the system that provides maternity care, how does it change health outcomes? Are those outcomes impacted by race? A multidisciplinary team of experts in research, legislation, and birth first developed a scoring system and then carefully ranked every state in the United States to find out where midwives are available and where midwives are integrated to practice within the healthcare system. The team scored each state on items like laws and regulations that support or limit midwifery, like the ability to prescribe medicine, access to insurance coverage, and smooth access to advanced care when needed. The results found that no state got the maximum score of 100. But states that scored higher at integrating midwives into the healthcare system were associated with higher rates of spontaneous vaginal delivery, higher rates of vaginal birth after cesarean, lower cesarean section rates, lower preterm births, higher breastfeeding rates, fewer interventions during birth, and fewer neonatal deaths. This is the first time these important connections have been established. In states where more Black babies are born, integration of midwives is lower compared to states where fewer Black babies are born. Access to midwives and density of midwives are also significantly lower in states where more Black babies are born. These findings highlight racial disparities in integration, density, and access to midwives. This is particularly critical given that Black families are more likely to experience complications and infant death. The researchers' conclusion: greater integration of midwives is associated with improved outcomes for families across birth settings, even when taking into account the impact of race. To learn more about your state's score, visit birthplacelab.org.
All right, let's put my earbuds back in. Can you still hear me now, Gina?
Yes.
Great. All right, so I'm going to create a little puzzle here of what midwifery integration looks like. And of course, this is not all inclusive. We encourage you to go to the toolkit and read more about what midwifery integration looks like as a whole. We just want to kind of create for you some ideas, which will hopefully help lead to you being able to see in your system or your healthcare setting where some improvements could be made. So first of all, first and foremost, integration looks like a culture of interprofessional partnership. So that means easy access to physician consultation and collaboration, including interprofessional education. It means valuing midwifery and physician care as equals, meaning that the right care at the right time is the overall philosophy. It means where community and hospital midwives are represented in the state perinatal collaborative, because if the state perinatal collaborative is about improving outcomes for everyone, we can't simply just focus on the folks that give birth in the hospital setting, right? And kind of just relegate others to the emergency care they get when they need to be transferred. Integration looks like where all midwifery credential types are recognized in your state and regulated according to the International Confederation of Midwife Standards. It means where birth centers are licensed and accredited or meet equivalent standards. It means where there are guidelines for safe and efficient, respectful transfer, and those guidelines are created through a collaborative process. So if right now you have guidelines at your facility for this and have a policy about it, but haven't included the midwives who may be transferring care to your facility in the creation of those guidelines, then that's something you should be doing. It means the sustained growth of community midwives and BIPOC providers. It means where outcomes data are readily accessible. This is key to integration, actually, and here at CMQCC, we are in the business of data and truly believe that data transparency can change everything. And I imagine that for those of you on the call who might have worries about midwifery care or aren't familiar with midwives, that if you were able to see data specific to your region that showed the safety and quality of midwifery care, that you would be more inclined to partner with midwives, right? So outcomes data is critical. Where midwives have admission and discharge privileges, where state laws allow midwives to practice to the full extent of their education and training, including prescribing all drugs and devices in their scope. This is critical. I mean, if philosophically midwives want to go to geographic areas of geographic disparity, want to work with minoritized cultures and people, but they can't do everything that they've been trained or educated to do, that is going to create a gap in care, regardless of the fact that they are a warm body in a clinic doing care for folks, right? So we have to be able to allow people to do what they're educated and trained to do. And of course, equal reimbursement and coverage for midwives and birth centers by all payers. So now we can flip that around as well and see it from the opposite viewpoint. Midwifery integration hasn't been achieved if policy and practice where you're at is founded on supervision rather than collaboration amongst colleagues. If patients receive disrespectful or stigmatized care or judgment when transferring to the hospital from a community birth setting, or when hospitals in your region refuse community birth transfers, or the refusal to believe that diverse care models are critical to addressing the root causes of healthcare disparities, or where midwives are privileged at your facility, but function only as extensions of physicians, where midwives can prescribe or access the medications, can't prescribe or access the medications they need to provide safe care, where insurers don't cover community birth, or midwives aren't easily accessible to the public, or otherwise engage in unequal reimbursement practices. Where CNMs are licensed in your state, but not CPMs or CMs. Or where we value or trust one midwifery licensure type over another. Where midwives in your region have a restricted scope of practice below their actual education and training. Or where hospital midwifery is embraced, but community birth is disparaged. We actually give some examples of this in the toolkit as well. Even very simple things. Like the words that we use and the phrases that we use, because words do matter. For example, a failed home birth, we often will chart that, right? I know I have myself written that. But a failed home birth is a derogatory comment. For example, we don't call a cesarean a failed vaginal birth. It's a cesarean because it's a whole other thing. A failed home birth might very well, in fact, be an appropriate transfer of care. We also should shift our language around the word lay midwife. If a person is a licensed or credentialed midwife, then a lay midwife does not fit what they are and actually reduces or stigmatizes what their education and training is. And out of hospital birth. Out of hospital birth centers or normalizes one side of birth over another. So community birth is a phrase that perhaps should be in now the normal vernacular. So let's look at California and what's actually happening right now, because there's some exciting stuff happening in California. Number one, we have a new state funding stream for the midwifery education pipeline. HCI, formerly OSHPD, is now administering state funding for midwifery education programs and student scholarships for midwifery students. There is a focus and on the growth of community midwives and BIPOC providers. For example, the Midwifery Mentoring and Belonging Program at UCSF and Cal State Fullerton, that's being funded by CHCF, and other scholarships and grants, for example, being given by the California Nurse Midwives Foundation and HCI that I just mentioned. There is a huge push towards advocacy for equal reimbursement and contracting. We also have a statewide collaborative right now for midwife-led care for Medi-Cal enrollees. We are one of 5 states that is participating in that collaborative. We're also actively trying to amend arbitrary state laws that restrict access to midwives. And we're seeing the rise of midwifery advocacy by community orgs and policymakers. And because California is really putting itself out there as a reproductive freedom state, we're embracing patient choice. However, in the background of all this are still some things in California that need some work. For example, there are few active endeavors to improve collaboration and transfer. So on that note, if you are in a facility that is interested in improving collaboration and referral and transfer from the community setting to the hospital setting, please email us, because we will be starting a community birth initiative in the next few months that will work to do just that between a few pilot sites. In California, we still are elevating hospital midwifery over community midwifery. Commercial payers unfortunately won't cover community birth or sometimes midwifery care in general at birth centers or in a clinic or hospital setting. Many payers, in fact, commercial payers are like that. We still see disrespectful transfer of care for home birth patients. There's also a dearth of available training sites for midwives. So this is where I beg anyone on the call in California, if you are willing to take a midwifery student, please do that, because we could have as many education programs as we want, but it wouldn't work out if we don't have the clinical training sites. So we also have a culture that, quote, utilizes midwives, but utilizes them as physician extenders instead of valuing the midwifery model of care. I have worked for large hospital systems in California that have the most midwives, but unfortunately, integration is not as you would think it would be just based on the number of midwives. A lot of times those midwives are being utilized to do very medicalized care as physician extenders. And we don't have readily accessible midwifery outcomes data, as I was talking about before. And there are other things like state laws that prevent patient choice in childbirth. We're unable to obtain medical staff membership and admission privileges. And this is important because midwifery practices can be just summarily dismissed. And we've probably, you all have probably heard of or read about very big practices in both California and in other states that just don't exist anymore because there's no due process for them. So what this has done, it's reduced the size of the California provider network. It's reduced or eliminated patient choice for pregnant people, overall has decreased safety and quality in some respects, and increases medical intervention. And ultimately, the effects of this are carried by mainly BIPOC patients, those who are socioeconomically disadvantaged and geographically isolated. But now let's zoom in on the micro level integration considerations that you all can think about integrating into your clinical site. So the toolkit does provide a whole list of strategies, and we encourage you that if you have any questions or concerns about these strategies, to be in conversation with us, because that's what our clinical leads are here to do, to help you as CMQCC members. But what we've designed in the toolkit are administrative, educational, and clinical strategies for your hospital to integrate midwives. We can kind of see it as a checklist. So number one, and first and foremost, are there midwifery attended births at your facility or within your group? If not, that would be a good place to start. And there are multiple tools in the toolkit, many in fact, that can give you a place to start. Do community birth midwives have privileges at your facility? That's an interesting question, right? And this is not just some wild idea. There are practices in California, birth center practices. I'm thinking Santa Rosa Birth Center, Beach Cities Midwifery, and others where those midwives also had privileges at the hospital that they transfer to. The reason that was important is because it creates a smooth transfer, a safer, quicker transfer of care, but also keep in mind that most community birth transfers are not emergency transfers. Only about 1% to 2% are. The other transfers are for pain relief, are for augmentation of labor, and all of these things still fall into a midwife's scope of practice. So having that continuity is really important to integration and important for patient continuity. Also, do your policies enhance collaborative partnerships, or do they rely on supervisory relationships? So as I was saying previously, there are lots of places that have many midwives, but their policies and protocols are set up in a way where there's a hierarchy and a supervisory relationship. What that does is it implies that the midwife must function and practice in a more medicalized manner. And if that happens, it may, not always, but it may actually reduce the benefit of midwife care and then reduce the potential improved outcomes that you would see if a midwife were able to simply practice midwifery. Do midwives lead quality improvement projects in your facility? If they're not, they should be, because especially those things that reduce intervention, that are highly patient-centered, like cesarean reduction, improving breastfeeding, etc. Is your department engaged in projects that improve safe, patient-centered transfer of care? And are you fostering a departmental culture that values reduced intervention and midwife-led care for low-risk birthing people? We realized in our task force that this was actually a key part of integration at the clinical level. If you have midwives at your facility and they can't practice midwifery, they're probably not going to stay there very long, for one thing. And also, you're not going to have the outcomes that you would hope from having a midwifery model of care. It's kind of similar to if a pilot was not able to fly a plane, but was told they needed to drive a boat. They would probably learn to drive the boat, but it's not going to do the thing that they were hired to do, right? Their practice wouldn't be able to survive in that culture. Just so you know, a key part of integration at the clinical level is team-based care. I'm not going to go through this right now because we have a whole other webinar that was done in February on team-based care, but let's not forget that component. I also always like to say that team-based care and collaboration is not integration, okay? It's a component of integration, but at the clinical level, it is key. And you can find that from February 3rd at CMQCC.org, and it will run through those key points of team-based care. Okay, it's 1 o'clock, so we have a half an hour left. I'm going to skip this part for now because in October, we will have an entire webinar dedicating to improving safety across birth settings. But the toolkit does also, as part and parcel of midwifery integration, go through the various components that are necessary from the improved safety across birth settings viewpoints. All right, so if you have questions about data center, you can email datacenter@cmqcc.org. Any clinical improvement questions or specifically about the toolkit can go to Krista at csakowski@cmqcc.org. And if you have questions specific to midwifery and team-based care or integration, or our future community birth partnership initiative, please email me at holly@midwiferyrising.org. All right, so I'm going to turn off my slides now, and we are going to go to the question and answer portion. So if the panelists want to take themselves off of mute. All right. Stopping my share. Hopefully that worked. All right. Well, welcome panelists. Thank you for being here. My first question actually is going to go to Dr. Mimi Niles. First of all, tell us a bit about your background as a midwife and now your work as a researcher. And we'd love to hear from that work, what are your biggest takeaway points from today's webinar as it relates to your work on and research in midwifery integration?
That's a big question.
It sure is.
So I've been a practicing midwife. I call myself a public health midwife for the past 13 years. And New York City has the largest municipal hospital system in the country, and many midwives in New York City work within that system. So I am one of those hundreds of midwives that works within that system. I'm lucky in the place that I've worked for 13 years. That's the only midwifery job I've ever had, in that the midwives are the primary attendants of maternity care. So despite risk, the midwives are attending to and caring for everybody. So I know risk is a buzzword, and it came up during this talk, and I do have very specific perspective on what it means to provide midwifery care across the risk continuum. I think that's something that we could definitely have another webinar about as well. During my time as a midwife, I quickly understood that there were so many system level factors that I was not trained to understand or comprehend. If anything, they were obscured from my education so that I would be sort of a productive member of the team. And in pursuing my public health master's, you really get that training around thinking about healthcare as a system, and that many of the choices that we struggle with or that are obstacles to care were actually designed into the system. They were not developed by fault, right? So inequities, disparities, many of those things were designed and built into the system. And so my work now as an assistant professor, a researcher, a midwifery researcher, I really research midwives is my passion, is to gain a better understanding of where midwives fit into this ecosystem of what we generously call a system, right? Because is maternity care in the US systematized or organized? I would say no, it's not. And that's why we're in the state that we're in. We have some of the worst maternal health care outcomes of high-income industrialized nations. And that is, to me, by design. And so my work, my passion for now, before I go totally gray, is to understand how midwifery care and midwives can optimally function across systems and across settings. So that's the perspective I bring. I myself had 2 home births. I did my integration with a home birth midwife. So I also bring that aspect to my own clinical work, but I'm a sort of full-on hardcore midwife who practices in a relatively low resource public hospital that predominantly serves Black, Brown, recently immigrated folks to New York. And I'm very, very proud of that. So that's a little bit about me.
And you noted, your work now is trying to discover how midwives can optimally function in our system/non-system. Are there any pearls that you've discovered so far along this work that would allow midwives to optimally function so that the patient outcomes could be what we hope them to be in an optimally functioning system?
Yeah, I mean, I think the presentation was so comprehensive. I really also want to applaud you and your team on the toolkit. What an amazing resource, so comprehensive. The pearls I have are that if these inequities and disparities were designed into the system, then we have an equal opportunity to design equity and joy and love and compassion into that system. And to me, the best provider to be able to redesign or revision what that looks like are midwives, because that is the core of our ethos and our philosophy of care. So beyond sort of the truckloads of data that we have that demonstrate better outcomes with midwifery care, what can we do now to really, because I think we're at a moment, as you said too, right? Like a tipping point or a zeitgeist, but hopefully it's more than a moment. Hopefully it's a movement of people saying what is happening in the United States is not working for people. It's working for very few people, and many other people are excluded from high quality, highly functional, highly integrated perinatal care, right? And so the pearls I have are, let's utilize midwifery wisdom, let's utilize midwifery philosophy, midwifery science, right? Because there is midwifery science to rebuild, revision, and transform what healthcare systems can look like, because the danger is that, like you said, a parallel system develops, right? Where people are making choices because they are, and I'm seeing this happening real time, people are making choices that are unsafe for themselves because they are terrified to enter into a system that is harming them, that is hurting them, that is killing them. And so what we need to do is really rebuild a system with the focus of, and always in sort of a critical feminist Black theoretical perspective, look at what's happening at the margins, build and design for people at the margins, and everybody's going to benefit from that. Everybody who enters into the system will benefit from that theoretical and philosophical approach to system redesign.
Thank you. I appreciate that. That's a really expansive and deep answer to that, which is something that we could, the pearls of midwifery, we could spend, again, another semester or entire webinar on. Do either Sue or Eva have anything to add to that?
I love those points, Mimi. I appreciate them. I think for me, the things that are really important in terms of establishing collaboration or integration is recognizing that as a home birth midwife, I have intentionally chosen to work outside of a hierarchical system, and expecting me to follow somebody's hierarchy is foreign, uncomfortable, and undesired. I also feel like that those elements of equal treatment are huge, and the piece that I continually strive for, that I think is the most important, is anything that helps us breed familiarity between the organizations that I need to depend on to support myself and my clients. And it's completely invaluable to have somebody like Eva, who was my colleague as a home birth midwife and now feels continuing as a colleague as a hospital-based midwife, and makes all of those resources accessible to people. There are 3 hospitals in San Francisco that support me, and I have on speed dial, 2 midwives to text at 2 of those that can help me and help my clients. And it's a small inroad, but it's invaluable.
That's really great to hear. And do you, on that, you have midwives that are at these facilities that kind of work as a midwife to midwife handoff, which is what I'm assuming happens many times. But also there must be a physician component here where the physicians at these facilities understand or either support or understand home birth or tolerate home birth or whatever it might be. Can you talk a little bit about what it takes, and anybody can jump in here as well, takes on the physician side to make this happen? Because it is true that without that support, this doesn't move very quickly or at all. But also in this system, we each have a specific expertise that is needed. We can't function without physicians. Physicians can't function without us, I believe. And so can you speak a little bit to, anyone speak to the partnering with physicians and what is, I guess, both has made it successful or problematic on the flip side?
Yeah, I can respond a little bit about that. I think one of the things that was communicated very early on here in the San Francisco Bay Area, as we were working to build an organization of hospital and community midwives and other perinatal care providers to really envision and create this idea of birth system integration, which I appreciated in your talk that you were very explicit that it doesn't actually have a full, clear definition, because I think those of us working in the field are have exactly what you described. Like, we have an idea of what it is, and we're going to know it when we're in it, and we've seen it, and we've achieved it. But it's we need people that like Mimi and people working in research to help us create some of those definitions so that we will be able to measure it. But something that some of the community midwives said very early on was, you guys need to do your work first before asking us to join in that work within your institution, because it's actually not always a safe place. Exactly commenting on what Sue you're talking about, it's not just something you might choose not to participate in, but it actually historically has been harmful for community midwives to enter the hospital system and to be treated as less than any other care provider, or to be spoken to in a very negative way. And I was certainly a recipient of that when I was a home birth midwife. So I was very attuned to that vulnerability. And generally speaking, when we're transferring to the hospital from community birth, it's vulnerable because our clients need something that we actually can't provide. We've extended all of our resources at home, or the client needs something that we can't provide. And so I think recognizing that, and now that I've been within the institution for, it'll be 9 years, I've taken that on as a midwife to really do the work within my institution to help my obstetrician colleagues really understand the context of community birth, the necessity of really building collaborative practice within our institution, so that, and that's not an easy feat, right? To actually do the work of understanding and creating a team-based care model that values midwifery care and obstetrics, the right care at the right time. That concept takes a lot of work. And so I think one of the things I learned pretty quickly was that we can't go straight into trying to build birth system integration if we can't within our own institution say that we have a collaborative practice model where midwifery and obstetrics are equally valued. So I think that requires time and definitely support from leaders within our departments. One thing that we did quite a few years ago, and I think was modeled off of the San Francisco General or Zuckerberg General, was including midwifery in the title of our department. Seems it's not insignificant. It's really important that midwives are named within our department so that we're not assumed to be practicing obstetrics. I think it really highlights for other hospital staff, for people outside of our institution, that we are an institution that has obstetrics, midwifery, and gynecology, and that midwifery doesn't get kind of lumped into or assumed that we are doing something similar to obstetrics, because they're different forms of practice.
Can I add too? I mean, I think about collaboration a lot, and I think until we name the force of power in the room and the force of power in the institution and who holds that power, collaboration doesn't work. You know, I mean, yes, there are individual physicians that I have really good, generative, respectful relationships with. But then every time a new attending comes in, or we don't have residents, but I've heard this in my research, a new group of residents come in, you're starting from ground zero in trying to educate them on what Eva said, the philosophy and the ethos and the specialty that is midwifery care, right? And so I think that midwives have to become bolder in directly pointing out where the power is in the room, and that is often with the physician, because the system is a medical hierarchy. And us trying to fit into a system that was, again, designed to exclude us, right? And actually prevent our model, just like that section you had on the tradition of the Black grand midwife. There were so many laws, regulations, at the federal level, at the state level, at the hospital level, at the county level, at every single level that you can think of, that were designed to exclude midwives from practice. And some of those regulations, they remain in the system. They're archaic. You don't meet them until you're trying to maybe open a birth center, and you meet them and it's like, uh-oh, we have this old thing in the books. And so we can't do this particular thing, or we can't offer admitting privileges to midwives practicing in home and birth centers because the hospital has these archaic bylaws that are going to prevent that from happening. So for me, integration is about also very directly addressing the power in the room. And let's stop calling it like team-based care and collaboration, because those are the terms we use so that our physician colleagues will pay attention and listen. What if we took another approach? What if we took a more radical approach and said, this is about the power of patriarchy in the medical profession, right? And your gender does not preclude you from being a patriarch. So let's remember, because OB is turning significantly a woman-identified profession, and things have not gotten better, right? That was sort of the party line in the 70s and 80s. Oh, when we have OBs that are women, things will change. Things have gotten worse, right? And so until we very directly talk about patriarchy and power and capitalism, because that is what drives healthcare, I just feel like we're also going to be circling the drain around what is really, really happening. And the other thing I want to say to Sue's point too, is what I see successful are these very individual relationships, right? These are the strategies that I know we have very high transfer rates from people who practice in the home that come to my hospital, right? But when we talk about European countries that are doing this better, do you know what they're doing better? The people who practice in the home also practice in the hospital. There is not this separation, right? They are part of the system. they are integrated into the system because the system is designed for the person. In America, the system is designed for the corporation, right? And so you have, like, I love when we talk about the European model, but let's be really honest about the European model too, right? It is integrated on all levels. So it's not just the right care at the right time. It's the right place and the right provider every time. All four of those things need to happen.
I perfectly said. And one of the things you brought up is relationship building. Sometimes this inability to see each other for who we are and the kinds of care we provide, and to deconstruct the stigma around midwifery care, et cetera, and doula care for that matter, and just different styles of practice, is building those relationships. So one of the things that's been done in the Bay Area is the Birth Bridges Perinatal Collaborative, which I feel could be replicated in other parts of the state if people have a motivation to do that and want to see some change. I would love to hear from Eva and Sue what the Birth Bridges Perinatal Collaborative is, what it works to do, and what pearls you might have on how to build relationships.
Yeah, I'm excited to share about that work because I think I'm excited to be a part of it. And I think those of us that have been working to build it are starting to see some of the impacts of that work. But it was, I think, around 2017 that I was at Highland and the lead midwife at Kaiser Oakland and the lead midwife at Alta Bates in Berkeley were all individually trying to work on how to move the needle within our institutions around this idea of birth system integration and really supporting and creating pathways for supporting community birth. And so we connected and then connected with some of the community midwives and formed a group. There was, I'm gonna say 6 or 7 of us, and equal representation from hospital and community birth, and came up with this idea, this concept of really creating this collaborative and not wanting it to be exclusive to just midwives, but expanding it to nurses and OBs and anyone that really is invested in this idea of birth system integration. And our goal was eventually to expand it and create shared learning opportunities and kind of do really what some of those basic concepts that were suggested from the Home Birth Consensus Summit, that were ideas for best practices, like what should we be doing as a community to really create birth system integration. And then when COVID hit, there was another kind of activation from additional hospitals in San Francisco and additional community midwives that joined into that effort. And so we kind of merged into what is now currently the current state of Birth Bridges. I think really our goal is to create a community where both midwives and clients and families experience the benefits of respectful mutual care, access to the hospital when they need it, and really highlighting the importance of centering this around equity, because as we know, hospitals have not been a safe place for, in particular, Black and brown people, birthing people, to get care. And I think COVID, in addition, added some extra momentum for people to really be thinking about whether they wanted to birth in the hospital, and whether alternatives were available. And so this collaborative really has been moving towards helping, and now we have other Bay Area hospitals included as well that are all individually working within our institutions. And we're not doing the major, I would say we're not radically changing the system, but from within the system doing anything and everything we can to help bring our physician colleagues along this movement to create birth system integration, really so that people can have the safe option to choose to birth at home and when they need to access the care that they need, and that they themselves, that families, and that midwives feel and experience the benefits of respectful transfer.
I think that's a beautiful summation, Eva, thank you. And for me, the most important piece of it all is having people, again, within the hospital system, working to get buy-in from the entire structure, saying, this exists, this is how we can be helpful, these are the pieces that we expect from either side. We created a document that, got sent up the ranks at multiple hospitals to have some buy-in and approval. And on one hand, it feels like recognition for community birth. And on the other, it's a little bit of a statement saying, we'll help, which is enormous.
Yeah, I think it's really, again, kind of translating what we, when the Home Birth Consensus Summit put out these best practices, I was like, oh my God, the United States can do it too. Like there's people who came together and they've put out these suggestions for how to do birth system integration and what we might do within our country. But it felt really hard to translate that into practice for the exact reasons that we've shared, that we're doing this independently. We're doing it in this really siloed fashion, not even state by state, not even region by region. It was like, really at the time, it felt like hospital by hospital. And because there was a midwife like myself, or like a midwife in any of these local hospitals that we know ourselves had a home birth themselves, or maybe did an apprenticeship or spent some time in community birth. And so they understood, deeply, truly understood the benefits and the safety and the necessity of community birth. And so within their institution, we're starting to try to move the needle. And I think we all recognize that it's really hard and it's really lonely to try to do that work by yourself. And so the more collaboratives we can have to support those of us in the hospital that are trying to really change the systems and help change the minds of the providers that we work with to shift towards really a collaborative relationship so that we can move towards birth system integration.
There is a question here that is kind of on that note. And it says, this is where it gets complicated at our small rural hospital as well. I understand not wanting to work within the administration and hierarchy of the hospital, but when transferring to the hospital, there is an element of needing to follow the hospital policies, procedures, etc. Perhaps working together for building the in-hospital policies with midwife collaboration. I think that's saying perhaps there's a chance of working together to create these policies. What tools do you have to help small hospitals build policies that are midwife transfer friendly? So first of all, email me if you're in California, because maybe you're a good fit for our upcoming initiative where we will be helping hospitals just like yourself form those relationships and potentially even design those strategies to improve transfer. That said, can you name some specifics, Eva or Sue, that have encouraged this work or helped it along, whether that be joint learning sessions or just the willingness and ability of having a champion reach out to the community birth midwives and begin to have conversations? That's just what's in my mind, but you might have more information.
Yeah, I mean, I think, there are probably hospitals where there may not be a known or an identified person that can be that liaison or that connection. And I think that's a problem if we have hospitals where there isn't someone that can begin to do that work. But I know for within our institution, it has helped tremendously to expand the leadership team to include more midwives. And I know other hospitals that have done that. It really makes a difference if we can be at more of the conversations that are not even specifically even about midwifery practice itself, but having midwives at the table offering our perspective as we make and develop other types of policies, like how we respond to emergency patients that arrive in the emergency room that need any resources from our department. So that's one thing that comes to mind. And then the other thing is, I think, highlighting and going back to what makes midwifery care in a hospital midwifery care as opposed to obstetrical care. I think if the hospital itself isn't and hasn't figured out how to value and enhance and prioritize midwifery care within the hospital, it's going to be a very far journey to just go straight to birth system integration from community birth to hospital birth, because it means there's no stepping stone and there's no, it's hard. It's not that there's not, because we have plenty of obstetricians within our state that are extremely supportive of community birth, but it's I think a lot harder for people within the obstetrical field that don't have midwifery alignment within the institution to do that. So I think that's an area to really explore. And for those of us that are already working within our hospital systems, thinking about resourcing from the toolkit so that we're identifying what are the things that we can do to really highlight the midwifery care. And one of those first things that comes to mind is intermittent auscultation, because it's one of those like really powerful tools that differentiates between intervention as routine and intervention as something that is thought about, whether it's indicated or not. So that's an area that I think might be, I don't know if it's low hanging fruit, but it's definitely a place where it's like someone had asked earlier in the questions, like, what's one QI project I could do to start that process? And I think there's a lot of resources for integrating IA, intermittent auscultation, into your hospital. And I think it's a very kind of logical place to start to really highlight what is midwifery. Well, midwifery thinks about whether electronic fetal monitoring is indicated or not.
I also think the expectation, when I bring a client in because we need something from the hospital, I certainly understand that we are going to be following hospital protocols. What I ask, though, is that the people receiving us understand that I am an advocate for my client and can actually play this beautiful bridge role where I help my client understand what the hospital expects of them. And I just don't want it to be adversarial, and too many times it borders on that. So that's the piece where having joint training projects together, or just the more that we can share information, vocabulary, processes, anything like that, it just makes it more familiar, less hierarchical, less adversarial. I'm not from
Agreed,
Canada.
and in
I don't know why I
fact,
said processes.
And this next question goes along with that. It says, are there other states that privilege CPMs in the hospital setting other than California? By the way, California does not, well, CPMs could work in the hospital setting if they wanted to, but there aren't any that I know of currently. So the laws are a little bit more lenient in that regard. I don't know of other states, and maybe Sue, you would know. I think CPMs in general choose to be CPMs because they prefer to do this work outside of the system. But that said, the question is, do you integrate community midwives into your education skills drills within the hospital? And do you get good turnout? This is one of the things that we have recommended in the toolkit is, in fact, there are many ways to do this. Sometimes it's not education or a drill. Sometimes it's just meet and greets and understanding each other's practice and where we work and what our population looks like. But it could be education, right? It could be case reviews that aren't maybe particularly associated with any real case, but are sort of like a theoretical case. It could be grand rounds. It could be a teaching session where midwives teach about their practice, and like we've done today, and the flip side of that, where the department teaches how things are done there to just get an understanding of the culture of care. So it could go both ways. Yeah, so have you tried these kind of interprofessional kind of sessions, and how has that worked out?
I know we have to end a few minutes ago, but yes, in fact, Birth Bridges, when we put out this little statement, we went to the antepartum, intrapartum conference that UCSF holds, and we tried to have, you know, a session where we could informally meet each other and talk about this statement. It was the first year of doing that, so it was very small turnout, but it was definitely something that we can build on in those informal kinds of settings.
Wonderful. Well, I want to say thank you to all our panelists today. I'm going to leave this screen up here, which has the QR code for the next webinar in August, if you'd like to register for that, which will be about partnering with doulas. And if you have further questions, I have actually taken some screenshots of those questions and who asked them. And I'll be in touch with as many of you as I can. And if you have further questions, feel free to email Krista or I. And you will find those email addresses in the PowerPoint that will be released in the next couple of days. So really appreciate you all, and thank you again to all the panelists.
Thank you.